Hi, everybody. My name is Joey LeClair, and this is my case presentation. So, my case is about Mr. Jerome Lang. So, Jerome is a 30-year-old man. He is a diabetic, and his A1Cs have been about 11. So, his triglycerides are also 1500. And we've discussed the options and decided that a medication for his triglycerides are needed. So, we have to choose a medication and explain to him about said medication. So, just to better understand the case, it's important to know that triglycerides are a type of lipid that's found in the body. Elevated lipids are linked to an increased risk of cardiovascular events, including strokes, myocardial infarction, and atherosclerotic disease. So, this patient suffers from hypertriglyceridemia, which severe hypertriglyceridemia or very high hypertriglyceridemia is when triglycerides are over 500 milligrams per deciliter. His are 1500. So if a patient has very high triglycerides, over 1,000, it contributes significantly to risk of pancreatitis. So the priority is going to be to lower his triglycerides. And then not only is he suffering from this, but he also is a diabetic, so we have to keep that in mind when we're choosing our medications. So the medication that we are going to choose is going to be fenofibrate, also called Tricor. So fenofibrate is in the fibrate class of medications which are used to decrease triglyceride levels. Fenofibrate's about 27 to 48 cents a day for the capsules, according to the NIH, just something to keep in mind. Um, and fenofibrate can cause about 30 to 60% decrease in triglycerides, as well as decrease in very low density lipoprotein. It also does have a slight decrease in LDL cholesterol as well. Its mechanism of action is that it enhances fatty acid oxidation to decrease triglyceride synthesis. It activates the PPAR alpha receptor, resulting in upregulation of lipoprotein lipase, an increase in HDL synthesis, and a decrease in apolipoprotein synthesis in the liver. It also results in the clearance of triglyceride-rich particles as well. Just all those come together to decrease triglyceride levels. The pharmacokinetics of this medication is that it will reach peak plasma levels in about 4 to 6 hours with a half-life of 20 to 23 hours. And it can actually reach steady state concentration at about 5 days. Its excretion is primarily through urine, about 60% of it, and stool, about 25%. The rationale for me choosing this medication for this patient was based on guidelines surrounding severe or very high triglyceride levels. So anything over 500 and older recommendations say over 1,000 milligrams per deciliter, you should immediately start a patient on fibrate therapy for the reduction of triglycerides and the prevention of pancreatitis. The initial goal of treatment should be lowering triglycerides when they are above 1,000. It can also, like I said, cause a 30 to 60% decrease in triglycerides, which is more than statin medications. It'll also decrease LDL cholesterol and total cholesterol. And unlike most statins, there isn't an increased risk of developing or worsening diabetes. And in patients with type 2 diabetes, it's been shown to decrease coronary heart disease events and strokes. So this is the pathway from 2007 of managing hypertriglyceridemia. It's very similar to current guidelines, but it's a very good image of the pathway. So first and foremost, if a patient has elevated triglycerides over 500, then you want to immediately initiate therapeutic lifestyle changes, optimize glycemic control if they have diabetes, screen for metabolic syndrome, and also search if there's a secondary cause of the high triglycerides. With this patient specifically, because he's over 1,000, then we immediately want to add a fibrate or niacin, and then consider adding fish oil as well. We are going with the fibrate medication just for a little bit better efficacy. So this is also in combination with lifestyle changes. not just the addition of the medications. The alternative medication, and actually this was the first one that I had thought of, was pravastatin. So it's another option for treating elevated triglycerides. It's a part of the class called HMG-CoA reductase inhibitors. They're also known as statins. There's about a 20 to 40% decrease in triglycerides when taking statins. This is a moderate intensity statin, and there's evidence for pravastatin specifically that there might be some positive benefit for diabetic patients, whereas other statins can actually lead to the diabetes. So this medication would have a much higher effect on LDL cholesterol than the fenofibrate, but less so the triglyceride level. And if this patient had mixed dyslipidemia, where both LDL and the triglyceride levels were elevated, then it likely would be the first choice. But just because his triglycerides are over 1500 and he's at such a high risk of pancreatitis because of that, the first line treatment is considered fibrates. So there is some evidence that you can use fibrate medications and statins together for dyslipidemia, but they should be used with caution just due to the risk of the myopathy and the rhabdomyolysis. Dose adjustments are typically necessary, and you have to go lower with the statins. Also of note, the price of pravastatin, according to the NIH, is about 41 to 58 cents per day. So for dosing and duration of treatment for fenofibrate, dose ranges are typically between 54 and 160 milligrams for patients with hypertriglyceridemia, though the 200 milligram tablets are also available. This medication can also be used for mixed dyslipidemia and hypercholesterolemia, and the doses for that, according to Stat Pearls, are actually higher. So because of this, I'm actually going to go with 160 milligrams for this patient specifically based on how high his triglyceride levels and the subsequent risk of pancreatitis. So we're going to start at 160. The dosing for fenofibrate is just once daily. It doesn't have to be taken with food, and morning versus night dosing is not an issue as well. This medication can be taken for long periods of time for treatment of hypertriglyceridemia and primary prevention of cardiac disease related to high triglycerides. It's also been proven safe in geriatric use, so they can be on this in older age as well. Drug interactions that are significant for this medication. Other medications that will lower lipids, as you can see, statins, niacin. With statins, the biggest risk would be an increased risk of myopathy or rhabdomyolysis. So you want to, again, use those with caution. When taken with bile acid sequestrants, it may alter fibric acid absorption. When taken with systemic cyclosporines, it may increase nephrotoxic effects of fibric acid as well. Niacin's a good one to keep in mind because niacin, as vitamin B3, is available over the counter, and when taken with fenofibrate, it may impact liver function and contribute to those musculoskeletal effects. It's often used in the treatment of hypertriglyceridemia and co-administered, but again, should be carefully monitored, like with the statins. Fenofibrate may also increase the anticoagulant effect of warfarin, so it increases bleeding risk. So 3 major adverse reactions to keep in mind with fenofibrate. Firstly, the muscle aches and pain, weakness, or tenderness of muscles could be indicator of rhabdomyolysis, myopathy, and this is evidence of toxicity of the medication. It's also a lot more common when used in combination with statin therapy. Fenofibrate can also lead to liver injury or hepatitis, and symptoms of jaundice would be a giveaway for that, such as yellowing of the skin and sclera. Pulmonary embolisms are also a major adverse effect of fenofibrate, and we'll talk about that on the next slide. We're going to talk about patient teaching specifically for these 3 adverse events first. So if they develop any new onset muscle pain or weakness, then they should stop taking this medication and let the PCP know as well. I'll also, prior to starting this medication, ask them to kind of take an inventory of their current muscle aches and pains, just so they know their baseline prior to starting the new medication so that they don't think that any type of muscle weakness or ache is a side effect. I'm also going to explain to the patient that if they experience any of the symptoms of liver injury, such as jaundice or the yellowing of the skin and sclera, that they should stop taking this medication and report this to the PCP. It may require changes to the dose or the medication choice. And then for the pulmonary embolism risks, I'm going to instruct the patient about the risk and tell them that if they experience any symptoms, most importantly, shortness of breath, difficulty breathing, chest pain, that they should call emergency medical services. So other client teaching points. First and foremost, this patient has to immediately start on a low-fat, low-cholesterol diet. This patient has very high triglycerides at a very high risk of pancreatitis, and this should be done as well as the fibrate therapy to really decrease those triglycerides. In addition to that, diet modification, exercise, and weight loss are also first line for high triglycerides and decreasing cardiovascular risk. So these should be done at the same time. For those diet modifications specifically, uh, trans and saturated fats should be minimized. They also say that a lower carbohydrate and higher protein diet seems to be the most effective for weight loss and triglyceride lowering. Alcohol and tobacco use are known to increase triglycerides, so they should be used in moderation if used at all. We should also recheck triglyceride levels as well as cholesterol about 4 weeks after starting this medication. So this allows us to determine if the dose is appropriate, if the medication is appropriate, and identify risk factors to know if other medications are needed, such as if LDL is high, we might need to start them on a statin. So for patient monitoring, we're going to periodically check the lipid panel for medication effect. Um, Certain guidelines say that if fenofibrate is ineffective after 2 to 3 months, then it has to be discontinued and changing medications. We should also look at renal function, specifically uric acid, BUN, and creatinine clearance. So decreased kidney function does increase the risk of adverse events and requires some dose correction. If the renal dysfunction is severe or the creatinine clearance is less than 30 milliliters per minute, then we should stop. Creatinine phosphokinase should be checked because it's one of the lab markers for myopathy and rhabdomyolysis, which is one of those significant adverse effects. And then we should also monitor hepatic function, liver function tests, to make sure that we're not prescribing it in active liver disease because that's a contraindication. These are the references that I used to find this information. Hope everybody enjoyed. Thank you all.